nice. All the food home. And I brought handouts from our last meeting in case you weren't here. At the last meeting, you can pick up those as well. And then I made copies of the minutes. So hopefully, because these minutes typically won't be this long for our other meetings, unless we have lively discussion, of course, but they were long, this little lengthy this time because of the yearly recap. So hopefully most of you got a chance to look at that over online, over email. But I will give those of you who haven't just a minute to look through it so that we can approve it. And then I did want to welcome, while y'all are reading over that, our other people, our other guests on Zoom. So that's Ms. Munoz, Ms. Bostic, and Ms. Watto. And then Sarah May is going to be one of our presenters today. So, all right, I'll give y'all a minute to look over the minutes.
So you'll go and tell Sarah that you've made her presenter so that whenever she's ready to share her screen, she can. Yeah.
Sarah, we're gonna
so you're in presenter mode, so you can go ahead and start sharing your screen because you'll be the first to present.
Okay, that sounds good. Thank you guys. And for some reason it has me as the host.
Yeah,
Yes.
we passed host so you can present.
That way
Okay, perfect. And it's recording.
Yes,
And
that's
that's
right.
okay with you guys.
Yes, ma'am.
Okay, perfect.
Okay, if I could get a motion to approve the minutes. And then a second.
This whole time.
Any amendments or edits to the minutes? Oh, none. So the minutes for October 30th, 2024 have been approved. Thank y'all very much. So today we have several presentations on tap, as well as a couple of reports that I've asked people to give today. But our first presenter is Sarah May. She is actually zooming in from the Houston area. And I asked her and her team to present to you guys today on, she's an epidemiologist, but on flu trends in our area. And our clinic staff, which Sarah will address in just a minute, has been tasked with reporting flu type symptoms in our area. And so we will start submitting flu reports, and then they collect data, and she's going to tell you about the data that they use to determine the trends and prevention techniques and things like that. So because we are in the midst of flu season, I think this is a really timely topic. So thank you very much, Sarah.
Real quick, before you start, Sarah, they asked, somebody is parked underneath the awning at City Hall. If you are parked there, if you could please move your car so you can park in their parking lot. They just don't want anybody to be parked underneath their covered parking. That's my announcement. Okay. All right, so Sarah, whenever you're ready.
Okay, and I just want to check the screen that y'all are looking at. Does it have like a section for notes, or is it just the slide?
It shows the section for notes.
Okay. try to get that resolved.
And I switched you over to a different speaker, so I'm gonna see if that worked.
If she can make it bigger, that might help out a bit. If she just.
Yeah, can you put yours in presentation mode?
Yes, I
That's what the lights are.
tried. Let me see.
There we go. That's better. And if you can put it in. No.
I'm using 2 screens, so I think that's the problem.
Yeah.
Okay. Does that look good?
Yes, that's perfect.
Okay, and can everyone hear me all right?
Yes.
Okay, great. Okay, thanks for having me. My name is Sarah May. I'm an epidemiologist over here at DSHS Region 65 South. And like Celeste said, I'm going to talk to you guys about flu surveillance, talk about a little bit about flu reporting, and then about trends that we're seeing so far this season, and then a little bit about flu prevention and things that we can do in the schools to help prevent spread of flu. Let me move this. Okay. So seasonal flu reporting is voluntary. So every case of flu is not required to be reported to the health department. That would take a ton of resources as we get so many cases every year. But we do have a regional flu surveillance effort to try to still capture flu activity in our area and make sure that we're aware of what's happening. There are certain circumstances where flu is required to be reported to the health department, and that's if there is a pediatric influenza mortality. So if a child dies and it's associated with flu, then that does get reported to the health department, and we keep track of that and do an investigation. The same goes for any novel or variant influenza infections. So you guys may have heard on the news recently of the H5N1 or the bird flu, and there's been some human cases. So if that were to happen in our area, that would be reported to us, and again, we would investigate. And then any influenza outbreaks or any influenza-like illness outbreaks that occur are also reported to the health department, and then we work with the facility and try to get that transmission stopped. So flu season is actually defined by CDC every year. It goes from MMWR week 40 to week 20. And so those are weeks that, like I said, CDC defines, but it's typically the end of September to mid-May each year. And it lines up pretty perfectly with almost the entire school year is flu season. So the first day this year was September 29th, and it will go all the way till May 17th. And we'll do our seasonal flu reporting effort through that time. So for our regional seasonal flu surveillance, we do get reports from local health departments in our area, from school districts, and from hospitals. So each week, our reporters submit their weekly counts through our electronic survey. So we're not asking for names of cases or anything for flu. We're just asking for totals. So how many flu cases have you seen in your facility this week? So we have it broken down by types of flu. So we have influenza-like illness, or ILI, which I'll talk about quite a bit. So I wanted to define it for you guys. But it's basically if someone has a fever and a cough or a sore throat, and it's not known to be something else, then it could be considered ILI. So if they have these symptoms, but they're, tested positive for strep, they have strep throat, then they're not considered ILI. But if somebody, if the nurse at the school sends somebody home because they have a fever and they're not feeling good and they have a cough, then that could be ILI. We also ask for totals of influenza A, influenza B, and influenza non-differentiated. And the influenza non-differentiated would be if a student returns back to school and on his absent note, he has written like out sick, had flu, but he didn't write if it was flu A or flu B, then it would just be documented as flu non-differentiated. So a little bit about trends, and our regional data goes into is one of the sources that DSHS uses for their respiratory surveillance report that they put out. So this report is put out each week. It's very good. It has a lot of information if you're interested in knowing where we currently are in flu season and what flu activity is doing across the state. And our regional flu data goes directly into this report as well. They also have a couple other sources that they use to pull information from. But I wanted to highlight here that the current activity level is minimal for week 45, which is November. Oh, this is blocking. Hold on. Which is November 3rd through November 9th. So activity level is minimal. Our positivity rate for flu is only at 3%. So it did increase from the week before, but it's still pretty low. And then you can see the regions reporting increase of flu or ILI is there's been 4 regions in Texas reporting an increase. So we are starting to see a little bit of an uptick in flu activity. It also documents the number of novel influenza infections, outbreaks, and pediatric flu deaths for the season. And for week 45, we had none of those. So this chart is really in the weeds with laboratory data, but I wanted to show it because for week 45, they subtyped the flus that they were getting, and 89% of them were flu A and 11% were flu B. So we're seeing a lot more flu A currently than we are seeing flu B. And here, I love this chart. I geek out about this chart, but it compares flu seasons. Okay, so our current flu season is 2024-2025, and that's the red line here. So you can see we're really just getting started in our flu season, and things are maybe increasing slightly over the recent weeks, but we're still at low levels. And you can compare this to previous years. So last year at this time, which would be yellow, we had really already started to increase and we were at higher activity at this point. A couple years ago, you guys might remember we had a really early flu season. So that's what this blue line is reflecting, that really early start to our flu season. And you can see, looking at the green line, the yellow line, typically we see flu season peak end of December, January, and even sometimes into spring. Okay, and then this is a really nice map because it shows you specific counties. So you can look at Walker County and say, okay, what was reported in Walker County for week 45? And influenza-like illness was reported, but we didn't have any reports of flu A or flu B. That doesn't mean that they didn't exist. It just means that from our flu reporters that do report to us, they only were reporting ILI. But you can see in surrounding counties in our region, we did have some flu reported. Harris County, that's this big red one, they reported both flu A and flu B. And I'll just say, as flu season progresses, this starts to get very colorful with lots of flu reported. So for our regional activity, looking at our regional data that we're getting in for flu reports, it's still low, but we are starting to see an increase. For flu A specifically and ILI, we've started to see an increase in reports in recent weeks. We have been getting flu B reported, but they've been at low levels, especially compared to flu A. So there's still flu B going around, but it's very low, which lines up with the laboratory data that we've been seeing. And there's been no outbreaks of flu or ILI reported in our region so far, but it is beginning of flu season, so this will change. Okay, and I just wanted to highlight this too because Houston Health Department puts out a respiratory disease report each week as well, and they have wastewater surveillance. So this is kind of a new surveillance tool that came out of the pandemic, or was made popular, I guess, by the pandemic. But Houston's been using it for things other than COVID, and so they do look at flu. And you can see our current flu season is this black line. And for both influenza A and influenza B, we're really looking at low levels. A couple years ago when we had that early season, that's what's reflected here in this pink line was the wastewater surveillance kind of lining up with that early spike in our flu season. So that's also available online. I have a link here. And then flu prevention, steps that you can take in your schools. So the first one is taking steps for cleaner air. And this is kind of a new recommendation over the last few years. This recommendation really came out of the pandemic as well, when they started looking at information on increasing ventilation. But cleaner air, increasing circulation, cleaning the air, maybe taking things outside, it can really help reduce the spread of respiratory germs. And so CDC has an entire web page dedicated on improving ventilation in schools. And so this may be something that you guys as the SHAC have talked about extensively, or maybe not. And so I have this information here because there are steps, written out that you can take to check your HVAC system and things you can do to try to improve ventilation and air circulation. And then just daily, like routine cleaning, sanitizing, disinfecting. Specifically, those high touch surfaces are going to be important for respiratory season. So doorknobs, keyboards, things that people touch quite often. And a lot of these recommendations help prevent like spread of any respiratory disease, not just flu. So we're seeing a lot of stuff going around right now. So that these can be taken, and help improve or stop transmission of all respiratory viruses pretty much. So just hand washing is another one, not only teaching and reinforcing proper hand washing, which can be fun. I've seen classrooms when they're in a flu outbreak, take glow germ and like really emphasize, hand washing and trying to make it fun for the kids. But also setting times in the schedule, like built in for the kids to wash their hands. And I know that this can take away from learning. So this can also be something that is done, like if you are starting to see a lot of transmission in your school, a lot of flu activity, a lot of other respiratory activity, even, hand washing is good for all viruses, or bacteria, even not just respiratory. So this could help with the GI outbreak or something. So this could be a tool that you use if you are starting to see a lot of illness in your school. Okay, we're going to start scheduling, times for kids to go and wash their hands. Respiratory etiquette, again, just reinforcing, covering their mouth and nose when they cough or sneeze. Having tissues available for kids, teaching them if they don't have a tissue to sneeze in their elbow. And then flu vaccinations. So flu vaccinations are the best way to prevent flu or prevent severe complications of flu. They are recommended for everyone 6 months or older every flu season, especially those at higher risk. People at higher risk can be young children, people that are pregnant, older folks, so 65 and older, and people with health conditions. So they can, if they get flu, they can get it really bad, and the vaccination can kind of prevent hospitalization. They do say to try to get the flu vaccine by October, but if you can get it all season long, and it should help, prevent complications all season. And this is something that schools can do to try to prevent, flu outbreaks later on in the season as things start to ramp up. Having a flu clinic at the school, either, just for staff or even making it available for the public, students, or just, letting them have time off to go get vaccinations. So I'm sure there can be some fun, creative ways to encourage vaccinations at the school district level. And then the last note is exclusions. So the school nurses are familiar with this, but there are requirements for when a sick kid has to stay out of school. And it's written into the Texas Administrative Code. There's not anything specific for flu, but there is an exclusion for fever. So people with a fever should remain out of school for 24 hours. without the fever. So they have to be 24 hours fever free without the use of fever suppressing medications. That's always a tricky part of that. So if they've been on Tylenol for the last couple days and haven't had a fever, they need to go off the Tylenol and make sure that they don't have a fever when they're not taking that fever reducing medicine. So really making sure that these sick kiddos are excluded so they're not, at school spreading it to other students, and even coworkers, can be an important tool for preventing disease transmission. And that's all I have for you guys today. I'm happy to take any questions. My information is right here with my phone number and email. And then I also have the information for our EPI program. If you'll have any questions or anything about reporting or any diseases in general, feel free to reach out to us.
Sarah, I actually have a question for you.
Great.
So you mentioned during the trends section, what do you attribute to the low numbers this time of year and maybe also in Walker County?
I think so for Walker County, that's taken just from our regional data. So we don't necessarily, like I said, there probably is flu in Walker County. It's just we might not have a ton of reporters from Walker County. So I would take that with a grain of salt. But I think that it's just kind of early in flu season, like beginning of November. I think maybe we're just gonna have a later flu season. It'll probably start picking up. I mean, it has started to pick up over the last couple of weeks. So I think, we're gonna have a typical flu season where we really start getting hit in December and moving on.
And also I wanted to mention to the group that we did host a staff flu clinic. It was October 29th. So we did offer that for our staff. We had a good amount of participation and they went from campus to campus to offer the flu vaccine. And then as Sarah mentioned, the policy for fever, we do have that as our policy. And we've actually had that a standing policy even before COVID. So our clinic staff is really intentional about mentioning that to parents, especially if we have a student at school that appears in the clinic that has fever, and we explain to the parent that, before they can, return to school, they have to be fever free for 24 hours. And of course, our limit is, temp of 100. So we do follow that rule as well. Any other questions for Sarah? Okay. Thank you so much, Sarah. We appreciate it. It was great information.
Great. Thank you guys. And thanks for inviting us.
And you're welcome to stay on if you'd like, or I know you're busy if you need to get off, but thank you again.
Thanks. And if I do leave, is it going to affect the meeting since I'm the host?
Sure,
Ms.
yes, it
Brock.
will.
Okay, I'll stay on.
I might be able to switch it, but I don't know how to do that, just to be real honest, so.
It's fine. I can stay on.
I can
That's
figure it
fine.
out. Okay.
And I guess we'll welcome Coach Miller to our group on Zoom. Thanks for showing up. All right, and then next, our presenters are Beth Dahlman and Michelle Garcia. We'll have Beth come up first. They are both from Tri-County Behavioral Health Care, and I asked them to come and present. Beth on she's a director of crisis trauma, and then Michelle will come up and discuss her committee in her area. Casey, do you need to? I know you're busy. I don't know if you want to go ahead right and wait. Okay.
I got to connect to the screen. Okay. You can stay kind of there.
Or maybe Casey, would you like to go ahead and report while they're setting up? So if we'll jump down to reports, I asked Casey Chitwood to come. He comes annually And I asked him to report on traffic patterns in the district, for morning drop-off and afternoon pickup. And it gets very, very complicated. They have a very hard job, as you guys have seen, as you come in and out of the district, and as well the safety issues that they take care of at our campuses.
I see a lot of familiar faces here. My name is Casey Chitwood. I've been employed with the constable's office now almost 7 years. I retired from the sheriff's office in Walker County. As Nurse Roberts said, we do all the safety. We're not here, and if y'all want to pass along this information to somebody, I know y'all have friends in the district, some of y'all are maybe, you can pass it along. I mean, we're not here to police your children. That's first and foremost. We're here to keep them safe. We're here to keep people from just coming on campus. I work the high school campus primarily. Deputy Wallace is at the elementary school, Deputy Burnett's at the intermediate, and Deputy Casper's at the junior high. If y'all have students at any of those places, you've noticed whether the officer's walking around or out in the car, making a loop or checking a gate or checking a door, because that's our primary focus, to keep people from coming into and onto the campus. I can just give you, from my perspective at my campus, I have a big problem with parents coming to their students' cars. And it's, and I know that sounds silly, but I'll say it this way. So if you have a couple sets of parents coming to their kids' cars every day, dropping stuff off, God forbid if an event does happen, so now we're accountable for the extra parents that are on campus. If they would just call the office would know that they're there, the office would notify me, no harm, no foul. But if 100 other officers are screaming down there because I'm screaming for help, and I don't know you, sir, but if you're out there in your son's or your daughter's car and they see you walking around, there's going to be a problem. If the office doesn't know about it, they see you wandering around, that's when there's a problem. So, and I have that conversation a lot with a lot of parents on a daily basis. I just thought I could, go to the impact center and drop off my son or my daughter's lunch, or, call the office. They'll let me know. And then secondly, the traffic. Y'all all drive through the traffic every morning. Most of y'all have seen me at some point or another standing out there in front of the old Waverly House, directing traffic. That's something that the constable started to do 6 years ago. 7 years ago. Just out of the kindness of his own heart, because he saw it growing. That's not our job description. We don't have to be out there, but we do it just to try to help alleviate some of the traffic. Any of y'all that have lived here your whole lives have seen the traffic get progressively worse. Those of y'all that have been here, we'll say 5 years, 6 years, y'all have seen it gotten worse, and it's only going to continue to get worse. The only thing that I ask for, and the other officers that work for the constable, use your blinkers, be patient, be smart. I know a lot of people think, hey, it's just a blinker, it's no harm, no foul, but when you're there's a lot of moving parts when you're standing in traffic, and you're like, for instance, every morning, I've got 3 lanes of traffic in front of me and roughly 4 lanes this way. That's a lot of moving parts. So I know it's no harm, no foul. If I have hollered at anybody in traffic in this room, do not take it. I have not hollered at you. That's not. Just don't take it from me. There's a lot of stuff that's going on out there, and y'all, you're worried about the way you're going, and that's it. So, and that goes, I'll say that for every officer, because it happens. I thought when I pulled up this morning that I recognized the vehicle that I said something to that came through traffic this morning. You got to remember, you're in a car, standing outside, there's lots, we talk loud. So, but that's mainly it. You've got to, the traffic, and I can't, if y'all want, y'all can feel free to come up there at 7 o'clock in the morning. Watch me put on my little yellow jacket or my vest, and you just get a glimpse as to what it's really like. It looks different when you're inside the vehicle compared to standing out there. Not that it's, any worse than any other day. Some days are better, some days are worse, especially when it's raining.
You always get hold umbrellas while you're out there?
It's kind of hard to do when you're.
I'll get you a little.
And I've had people.
Yeah, umbrella.
I've had people,
Put that
I've
on
had
your
people
visuals.
stop in the middle of traffic, and go, you need lighted gloves. You need to hold a stop sign. You need to do-" I'm telling you, I mean, it happens. It truly happens. And that would be fine if that's all you had to do, so. Again, I want to reiterate, and I think the constable would back me on this, we're not here to police children. Now, I would say 15% of our, 20% of our job, would go to the policing side. Because God forbid, little Susie, little Johnny takes their AirPods and they get taken at school. Happens weekly, their phones, their $500 tennis shoes, their, I would suggest, I really would, I would suggest that they not bring those things to school, because it's gonna happen. And I started giving a speech that says nothing to do with safety, but this is just a parenting thing. If y'all wanna pass this along to some of your friends that are in the district. I had a daughter that graduated 3 years ago, 3 or 4, years ago.
Yes,
I
yeah.
don't remember, she's 21 now. So watching it firsthand, watching your children go through school, especially, and I say the high school. You please pass along to your friends. If you're not this way, then you need to be. You gotta speak to your kids. This, wherever my phone is. Y'all, I wish that, and I'm gonna try to get something set up where I can have some visitors come up there with little visitors tags and watch the students, how they interact or the lack thereof with their certain peers. People the same age, walking down the halls, it's crazy. It is, and it's mind blowing, because I know how I was in school. I know that was a long time ago, and some of that with y'all, but got 2 high school students right here that can attest to some of what I'm saying. If you don't speak to your kids, you're behind. And I say that coming as a parent. I know most of the people in here are parents that have had kids in school. And it's as simple as asking how their day was. That starts the conversation. Don't take anything away from here today, take it, because I see it daily. I try to speak to these kids, as a father, not as an officer standing in there with a gun and a badge and, all kinds of equipment on. I try to speak to them, hey man, how's your day going? Smile a little bit more, whatever it may be. I'm sure they've heard me say it a time or two to somebody else. I don't know, but, pass it along to your friends and your families and your neighbors. Talk to them. Don't plop them in front of the TV. Don't expect it to be, I get it. We all work. I work a full-time job. Y'all all work full-time jobs. It's busy. And I'm not saying anybody in this room here is doing anything wrong, but I'm passionate about that, because there's so many kids and I can see it in their faces as they're walking through the halls. It's just, some of it's sad. So speak to them, tell your friends, your neighbors, if they're not doing it, if you see their kids outside, breaking up rocks with hammers, we're taking interest in it. So, we're easy to find. There's one of us on every campus. You can call 911 if you have to. I mean, there's numerous people in this room that have my cell phone number, so if you need to reach out. And that's about all I have. I'll wrap that up for now. Y'all have any questions? Any at all? Yes, ma'am.
Mine's not a question, it's a
Yes, ma'am.
statement. Thank you for all of y'all for what y'all do to keep
Yes,
our
ma'am.
kids safe. And
And
standing out there on 75, I pray for y'all every day. If that drives by, I just hope in the
I worked for the sheriff's office for almost 23 years, and and I told my boss, and I told other people in the community, I told Miss Angela over there, I'm sure I told Stephanie, that this job, I didn't know. I had no earthly idea. But getting to watch a lot of these kids, especially my own, go through high school, get to watch some of that, see them grow, see them flourish. And you can just tell a difference in some of them. I know Jess can too. It's really has been it's been eye-opening, because if you'd have told me 10 years ago, you're gonna be working in a school, I'd be like, no, no. It really has been. It's been good. It's been good to, so I said a minute ago that I started speaking to freshmen, incoming parents. I don't speak to the students, I speak to the parents, and that small spiel, I've got about a 20-minute spiel that I give to the parents. Because it's something that I noticed very early on in my daughter's high school activity. Some of the kids that were around, some of the girls that she would bring home, it's sad. So, yeah, talk to your friends, talk to your neighbors, talk to your cousins, aunts, uncles, get them to. And it's not that we've got a bunch of bad kids, it's just that the kids need reassurance. And most of that comes from the parents.
And we started that, I think, a couple of years ago, where Casey would come to freshman orientation and speak to parents as they kind of rotated through sessions.
Now, this was my 5th year to do it.
Okay. Oh, your 5th year.
This
Okay.
was my
I
5th
guess I
year
was
to do
thinking
it.
it was just recent. Okay.
So, and like I said, I enjoy most of the kids. I really do. 98% of them.
And they enjoy you too.
Some of them,
Just a conversation, like, it makes a difference.
some of them.
And just to let y'all know how dangerous it is when he is out there directing, he has told me stories where he's actually gotten hit by cars or trucks that, I hope you don't mind me mentioning that, but just the reality of, you might think, oh, he's cool
I got
standing
the
out
last time
there.
I'll just tell the story. Last time, and I don't even think my boss knows this, but I got hit, and she's local.
It
I know-
wasn't
I
me.
know who it- She didn't do it on spot because we go way back. She's local, won't mention any names, won't tell what she drives, but she got so close to me and I've been standing there in the same spot. I mean, that's 16 inches between those, and I hate to tell y'all, but I'm wider than 16. So she hit me with a mirror. I don't know, probably 40 or 45, caught me in the left shoulder. Folded her mirror back, and I just kind of turned around and I looked, and she's looking. I can see her. She tapped her brake. She kept on going. I'm just like, really? So I saw her about a week later. She goes, "Did I get you with my mirror? What do you think?" The trailers, people driving by and their fenders, they're turning and they'll rub you in the back, or But just kind of, you gotta keep your head on the swivel. There's lots of moving parts out there. And I'm serious. I have a vest. If one of y'all want to come out there and watch, stand right there with me, I'll let you do it. You don't have to do anything, but just stand there. And there's just lots of moving parts. It's hard to describe. So it is what it is.
Well, thank you.
Absolutely.
On this bed, you guys can hand out, there's just flyers we made. So as she said, I'm the Director of Crisis Services for Tri-County, and I don't know if you realize Tri-County is a pretty big agency. We cover 3 different counties, that's the Tri-County Act. And there's probably 400 plus employees that work there. Some of them are office-based and some of them are field-based. And I was really glad to see that he was here to present, because he pulled in right as I was running out there to move my car, and I was like, oh, pull my car off. Yep. So what Michelle does over at the Huntsville Clinic is very different than what I do on a daily basis, and we all kind of go in different directions. But my area of focus is all about crisis behaviors. So it could be somebody who is maybe feeling a little depressed and they're having some suicidal thoughts, all the way to the person who's been diagnosed with schizophrenia and hasn't been on their meds, and they're acutely psychotic and putting themselves in danger. And anywhere in between, we see a lot of voluntary patients, and we see a lot of involuntary patients, people that have been put on an emergency detention hold by law enforcement or by the courts. And we see kids. I think the youngest kid we've ever assessed is 3, and the oldest person we've assessed is 99. So we cover a wide range of different kinds of folks. And so one of the things that we realized after a while is that kids, when they're experiencing a behavioral health crisis, it was very, very different than an adult, right? Adults oftentimes have, maybe marital problems, they may have, drug abuse going on. And their mental health diagnoses are very different. You don't see kids really, excuse me, that are psychotic, not on the norm. And, they're more kind of, their environment is usually impacting them quite a bit. And their coping skills are not yet developed. So we've had mobile crisis outreach teams for many years. And the way that they kind of determine who is eligible for a mobile crisis response is if they're suicidal, homicidal, or psychotic. Most of our assessments are done in emergency rooms, although we do community assessments too. And the adults tend to end up in different facilities. They may start with an emergency room, and then, excuse me, they may go inpatient, but they're always kind of like going towards some kind of institution. Sometimes they end up in jail. And we really just talk to the individual. We don't spend a lot of time talking to the family members and the other people involved. So for kids, we realize that their crisis may be about, it may be because they're being extremely destructive in their environment, and that's not their normal behavior. They may be physically assaulting peers or adults, and that's not their normal behavior. They may be doing things that are very, very risky for a child that wouldn't be considered risky for an adult. So they may be like running off into traffic or without watching, or they may be, trying to think of a good example of a high risk behavior for a kid. You guys could probably tell me whether we're not playing right now. But things that are putting their lives in jeopardy. So we can respond for those reasons, which is different than an adult. And we also realize that kids are very much impacted by their environment. So school is a huge influence on what's going on with them, their interactions, both with their teachers and with the other students at school. And then, of course, their home life also affects them. So you may have a kid whose parent says they never act like this at home, it's only at school. Have you ever heard that before from them? Yeah. And then sometimes we hear they do this at home and not at school. So it can go both ways, but generally we're looking like what's going on at school, where they have expectations of them, they have to follow the rules, they have to, they have to sit still at times, which they may not have to do at home. They may not be getting that same level of guidance at home that they're getting at school, and it's hard for them to adjust to it. So the state came up with this great idea to develop a youth crisis outreach team. And they picked 9 of the behavioral health centers in the state of Texas. And there's 39 total. And we were one of those centers. However, ours became focused on this special population that the state was worried was needing some extra assistance. And part of the reason that we were really interested in joining this pilot project is what we were seeing from kids last fiscal year. So for us, that's September 1st of 2023 till August 31st of 2024. And these were the services that we provided for kids, just our agency during that time period. We're seeing a noticeable increase in the number of kids that are ages 5 to 9 that are having behavioral health crisis. And can anybody think of why that might be? This year's been really bad with the 5 to 9 year olds.
Kids are making fun of each other.
Right, but that's been going on for a long time, right? And so we didn't used to see this kind of response from the 5 to 9 year olds. This is only a hypothesis. I don't know.
Cell phones.
That's been, yes. So I'm old enough to be able to say I've watched this change in kids with cell phones. And it's a huge thing. But we're thinking the 5 to 9 year olds are because of how old they were during the pandemic. And so they were not getting not the same level of social exposure that they normally would. Parents probably had a lot more stress. So if, in another year they say, oh yeah, this is it, then we'll be like, yes, we were right. But it's really, really been difficult this year. Some of the school districts have been calling me, asking what to do to help this age group, and we're still trying to figure that out. So the special group we got put into from the state was what they called YCOP Plus. We're not super happy about getting the plus part because what we wanted to do with the YPOP program was kind of sidetracked in order to meet these requirements. But it's really about this group of kids in the state that are really, really at high risk, and those are kids who are involved with the FPS. Sometimes it is just because they're in the middle of an investigation and they may have family services provided, but the child's behaviors are putting them at risk of being removed from the home. And then the other group is those that are already in the conservatorship with the FPS and they're in some kind of foster home, group home placement. And these kids are moving all over the state, and I've become acutely aware of it since working with this program, that these kids are like going all over the state. So they're not getting any consistency in their school environment, in their home environment, and not in their mental health services either. So as you can imagine, if they're seeing a therapist here and they move to, Dallas, all that changes again. So they wanted to kind of put something in place where there could be a more intense response on the front side. They also tend to cycle in and out of psych hospitals all the time. And that almost becomes their coping skill, is that they're getting overwhelmed, they'll just check out. And then they come with a bunch of meds. Anyway, it's a real mess. And so the states finally recognize this and they're trying to be a little more involved in what happens. The other high-risk group we've seen, especially since COVID, has been those kids with IDD diagnosis. Sometimes they're not quite diagnosed yet, but everybody's like, oh, that's not looking normal. We probably need to evaluate. Sometimes they do have the diagnosis. But because, again, they were isolated so much, when schools shut down, oftentimes that was the only real interventions they were getting was in the school environment, so they lost that. And the outcome of that is there's been a lot more 911 calls because of the kids and adults with IDD, and just a whole other approach to try to figure out how to help this group, because most of the systems involved, like psych hospitals, are not designed to help this population. So this was kind of my my sarcastic approach to the state, but they said, we want you to serve all these kids and do all these things, but we're only going to give you a small amount of money to do it with. And they want it to be 24/7, but we couldn't fund it for more than 12 hours a day is the most that we can fund it for right now. They didn't give us really any guidelines to use. They're kind of like, here's some general guidelines, but we want you to figure out what works best. So we've been doing this kind of like, that works, this doesn't, back and forth. So it's different. We're normally getting things from the state that are so rigid you can't do what you want. And this one's like, oh, do whatever you want to. It sounds fun until it doesn't work and you have to go back to the drawing board. So we have this, our team is 9 staff and 1 coordinator. They work 7 days a week. They're available for deployment 10 hours a day, just meaning that because we can't have them getting a call at their last hour of their shift, or they'll be there on overtime all the time. After they are seen by the crisis response team, as long as they meet that eligibility of some kind of DFPS connection, then we can serve them for up to 90 days. And the point of doing that is to help them get connected to the services they need, give them that support to help them kind of learn to control those outbursts on their own. And also just try to avoid them getting arrested, going inpatient, all those cycles that we keep seeing all the time. One of the things we have addressed in Walker County most frequently since we started this are these kids that are put in kinship placements by DFPS. And then DFPS checks out, closes the case, and they're in a safe place, but that kinship provider doesn't have any legal authority to consent to their treatment. So we've been working with these families to try to help them get the legal documents they need so they can go to outpatient services and not have to wait till it gets to the point of an emergency. Their calls go through our crisis line. That won't make any sense to you, but what it says is basically we can see kids that have a lower level of crisis eligibility than the adults. And we can respond anywhere except we cannot go to emergency rooms and we don't go to other tri-county clinics. So like if there's a kid at the Huntsville clinic, the idea is that they're already being served there and we're not gonna respond. However, we will follow up with that kid, and if they're eligible for the 90 days, we will offer that to the family. Our goals, like I said, is to reduce law enforcement, reduce emergency departments, try to avoid unnecessary hospital admissions, try to keep all these placement disruptions if the child's behavior is making them lose placements, try to get that under control, try to get rid of all the barriers to treatment. And we really focus on assessing the whole situation, like an MCOT assessment is really like short. It's about what's the risk, what's the factors, what do we got to do, and they go on. These are longer. They can be an hour, 2-hour assessments because we're really trying to get the whole picture and work with the youth and the family on de-escalation. This has been a real challenge for me. I don't know if y'all have ever spent much time working with the FPS, but they're complicated. It's really complicated, yeah. Trying to understand their system, like if the kid is placed here but they were removed from Amarillo, they're social workers in Amarillo, which I get, but it's really hard to make contact with these people all over and then figure out, the kids are always being asked to tell their stories all the time, and some of their stories are pretty intense. And so they just they lose track of like what's a bad thing and what's a good thing because they're telling their story so much. We also find that the FPS likes to take the path of least resistance. So whatever the quickest answer is the one they're taking. So we're trying to kind of re-educate them, like, let's try this path and we'll help you do it. So we've made some progress, but I'll tell you that first month was difficult. Like they were chewing me out all the time. They just didn't want to hear something different. Trauma, we're seeing so much trauma that I am now actually looking for some help for my staff because they're seeing some bad stuff. But what we see with the kids is that most of their responses are trauma induced. So if they've grown up with all this trauma in their life, excuse me, then their brain forms differently, right? Like the amygdala starts forming differently, and they're perceiving danger when there's not really any danger there. So then they have this kind of fight-flight response. And I had always thought that when they were at the fight mode, that was the more intense level. But what I've learned is it's the freeze mode when they are at the highest level of anxiety. So we see that a lot where we get called because they're in the yellow zone, but by the time we get there, they're hiding in the closet, under a bed, wherever, because they've gone to that next level. So we try to find ways to help them kind of make that curve and not quite get to the same intensity each time. And you guys, I'm sure, see this in the schools with the kids where you'll see them kind of amping their way up. And then, what we're doing is going in and trying to help them recognize when they're first starting to escalate, and then helping them identify ways for them that they can bring it back down again. But if they don't recognize it, then they don't know when to try to use those skills. This is old because I read it in October, but we really had a good response. We still do. The schools have been a little difficult to get into sometimes mostly because the biggest school system we work with is Conroe ISD. They have like a lot of rules, and they at first were like, no, we don't really want y'all to respond here, but we've kind of shifted that a little bit. We've been able to go into the schools more often, and that's been successful. And the DFPS folks they're coming around too. So we try to respond within an hour. I don't like to promise that because if we get 6 calls at one time, we are not going to be there in an hour. But that is our goal with each call we get, is to respond on site where the child is within an hour. And all this is just to try to help some of these high-risk populations get a little bit more stable. The state is really, really looking at this YPOP model. In fact, next week I have to go sit on the panel with the state meeting. He's going to be there too, to talk to the child behavioral health folks across the state about what we have found and what's working and what's not. So, I see the state funding LIPOT, and when they do, I'm hoping it won't have that restriction about the DFPS connection. And, we'll be able to serve all kids this way, because it really does help and it makes for better outcomes. So, that you guys have questions?
I do have a couple questions. As you know, crisis can mean many different things, the whole spectrum.
Right.
Relatively small stuff to all the way to, actively suicidal, depending on the timeline and stuff.
Right.
The 1 hour response time is impressive. And I saw you mention a couple of times trying to reduce, emergency services and that kind of contact. If, let's say, for example, in this scenario, like a 17-year-old calls you actively suicidal, you still try to keep that hour response time, or are you calling for like a welfare check?
No, as long as it's within our time, within our area and our hours, then we are trying to make it
Nice.
within an hour. And we are prepared to be able to do virtual assessments if we feel like maybe we've got too many other stuff out in a different direction and we're not gonna make it. We'll try to connect to them virtually. As long as, if it's a home that we've not been to before, then we send out 2 staff at once. And then, even then, if we feel like there's too much danger, we might ask for law enforcement just to come and clear the scene for us. But other than that, we try to avoid having to call law enforcement.
Right.
And it's nothing against law enforcement, but they have their guidelines. So we see this constantly. So 17-year-old suicidal, please show up. They call 911, please show up. Police here, kids saying they're suicidal, they have a plan. They put them on an emergency detention order, take them to the ER, and maybe in a day or two, they'll end up in a psychiatric hospital.
I'm looking there too.
Right.
Yeah.
And the amount of trauma they experience through that process just adds to so that's kind of the cycle we're trying to circumvent and address what it is and not just like throw gasoline on the fire, right?
The other thing is, in this case, this guy's a minor, guy or gal is a minor, and a lot of these times, patients that have had problems for many years, it can be related to the parents, whether the parents are, neglectful or, abusing drugs or what have you. This patient's a minor, parents in charge of the patient. Where is that line where you can kind of step in and overrule this, the mother or father and get this person the care that they need? Or does the parents still have ultimate decision to say, hey, no, get the heck out of my house?
You just opened a big can of worms. So, so like, I'm trying to remember, I think it was maybe 7 years ago, the state changed the statutes for minors being involuntary. So it used to be they had the same guidelines as an adult, and if a professional, like a psychiatrist or somebody said this kid has to go to the hospital, they're at imminent risk, and the parents were disagreeing, that could be overridden by filing an OPC and doing all these things. But they stopped that, and they said the only thing that can apply to kids now is the emergency detention order. So the law enforcement can put them under emergency detainment, which requires that they either go inpatient or that a psychiatrist evaluates them and determines what needs to happen. The problem I see with that is that it's almost like each officer defines that differently. Everything from that doesn't hold mustard at all because parents' rights trump any of that to people that will actually enforce it the way it's written. So I'm always really anxious about that because I don't know which officer I'm going to get and how they're going to define what the law says. The only alternative that we have if we feel like a child is at imminent risk and we can't get the parents to comply is to call CPS, and they're so overwhelmed they don't generally I shouldn't say they don't respond, but it may not be as quick as we would want them to. So it's kind of broken right now. Yeah.
And as a whole, the system has a lot of flaws. Last question, after hours, what are we telling these folks? What's their lifeline in the event of a crisis when you guys are not available?
So the crisis line is answered 24/7,
Okay.
and they have bilingual staff available if they don't speak English, but they will guide them through that. So they can either go to our PET-C, which is open 24/7, and be assessed there. Or they can go, the old route, the emergency room and all that. But, the pet C is really the better option for a kid because you can assess them and get them moving whichever direction within 2 or 3 hours. It's in Conroe, off of 2854. It's just down from the main library, off of 45. It's actually it's not far from here, not as far as I thought it was gonna be. But they are there 24/7. They have we have a contracted law enforcement officer on site. So if there's ever a need for law enforcement, there's somebody there. And if law enforcement, we have law enforcement officers that bring us people. For a kid, we always have to have the parents as well. We can assess a kid without a parent if they're suicidal, but we can't do anything after that. We can just say, okay, we've assessed them, but now we need the parent. So sometimes when we get called to schools, the parent won't be there. We just want to make sure the parent knows that we're coming and why. And then when we get to the point of this is what needs to happen, we have to have the parent. Now, the laws are interesting here because a 17-year-old can technically sign themselves into a hospital, but they cannot consent to medical treatment. So they can sign themselves in, but the doctor cannot give them medication until they have clinical consent. There's a lot of loopholes in there. We don't tell the kids some of the loopholes just in case they don't know. So like they could technically sign themselves out if they wanted to at 17.
Well, thank you,
Oh,
Beth.
I think Emily had a question.
Oh, so sorry.
Excellent.
Yeah, go ahead.
So my previous district, we worked really closely with them. They were in our schools at all times, and now I work out here. How can we, and maybe this needs to be a conversation after this, but how can we get you guys more involved with kids here and parents that might not know, I just don't think that we utilize you guys as much as I've seen the great things. Like I saw you guys in our school weekly doing counseling sessions with kids and things like that, that maybe parents can't take kids to counseling, maybe they don't have ways to get there. And I'm the director of student services, so I'm kind of over that kind of like all of our at-risk kids and things. So how can we get something going more here with you guys more involved?
So Michelle is she's the administrator for services at the Huntsville Clinic, and so she's gonna talk next, but basically that's kind of the starting point, is having them go through intake. And they do have great programs that work with kids because we understand that parents cannot come in every week and do these things. So they commonly will set it up with the school's permission to come see them. I think they do it like during their electives. They'll work with the school to find out the best time for that kid on a weekly basis and come see them for their skills training sessions in the school. And that way the kids getting the services consistently and the parents are not having to take off work all the time. So, but she'll talk to you more about that. Okay, I sent around the flyers. If you want my business card, I'll put some of those out too. But just let us know. Let me know if you have questions. Email is usually the best way to get hold of me because I'm always running around places. Okay.
Michelle. I guess if you guys don't mind, I know we're running over our time. Go ahead. I know you're.
So, I was on the inside services, I'm an intern for a lot of Washington. And like I said, we don't require any kind of referrals, but we do see it often from referrals from school, law enforcement, DSPS, things like that. They come into intake and try to do the same day. I pass it off in flyer where walk-in on Tuesdays and Thursdays from 8 to 9:30. That's the time that they come in and triage their assess and do a financial, so the families know right then and there if there's anything what that would be. Board services, there's a list of documents that are required on that flyer as well. And we do those because we look at board. Crisis services, that's the exception. They can access crisis services without having those whole documents. Once we have them in services, they're assigned a case manager and into a second determine recommended level of care. Typically, that is skills training, so social skills, manual management, coping skills, things like that. With skills training, we do send to do in the schools. We can do community, home, or office in school. We do try for elective, special, things like that, so we're not cutting into that for time. Typically, it's an hour a week. Some families prefer after school, so they'll come to the office, and we'll go to their home and we can in the community. If there's ever a time where, let's say, the school doesn't have a space available, or, let's say, conference or training that day, with parent permission, we can check them out of school, take them into the community for a little bit, for the second, and then take them back to school, for that as well. And then we have case management, services like psychiatry, partner support, so that's really for the parent and guardian. Those folks have kind of been there, done that, and have raised programs like health or behavioral health, or finances and navigating some child services. So they can also have opportunities to get that. Yeah. And then we have therapy and stuff like that, and stuff like that. Crisis services as well during business hours. A family center and child into our parents and that's our local credit coordinator, and then the next steps to discuss, or they can always go to down in Congo.
We didn't plan that, but it's like the people are flying, it's like, all my people are standing strong.
And it's really just meant to connect people with complex needs to services and benefits. So this is really for folks who, come to the environment. And so they're all coming together as multiple organizations. It really helps them in their one-stop shop, so as long as the resources are available, and so they can keep it. With water money, we found something available. So we can do that, pretty really, it is not a resource available for what that may be, and navigate that. And so really, really do like, and sometimes, maybe the gap in communication, and then we don't let it all out. Then people often say, with juvenile services, there's also hospital to follow forward. There's a tender as well as juniors. They do go through the CRCD process, they get a little more formal appropriation. And so oftentimes juvenile services will, look for a CRCD in those cases. And sometimes there's a tender administration. You will come out kind of like the fourth Tuesday of every month. And one of the hospitals, and then depending on how many families we have, also how long the meeting will last. And then small follow-up with the families, I create a service plan, so they get all the resources. Typically the person can refer them as well, get a copy of that, so they can help like this. And if we have any staff, they can do that as well. And it's included a CRCD flyer. It's my sorry, so far, I have any problems. I think that's going to be helpful.
And I've actually been, it was a couple of years ago, to one of the CRCG meetings for a student, and it is very well designed to provide resources for that family. So it's very all-inclusive, so it works out really well. Thanks, Michelle. Our next presenter is Erica Williams. She is our athletic trainer through Texas Children's Hospital. And the reason why I like to have her come is she is part of our health services team. And she collaborates. Some of you parents may already know her if you have student athletes in the home. And she collaborates with our clinic staff in providing services, mainly at the junior high and high school. obviously for the sports, part of that, but we have had her see students at elementary and intermediate, so her age group is all encompassing, when we need her.
Hello, everyone. Like I said, I am a Texas Children's Outreach Athletic Trainer, so what that means is children in each of the district. I'm available on most, like, two motions. I work with our coaching staff and our administration, and if they need me to come over to the middle school, I'm happy to do that. Most of the sponsors are athletic medicine, so here on campus for all athletic periods, which run from 11:30-ish until the end of the day. I provide after-school treatment time for our athletes, and then I'm here for all codes and that. So do a lot of different things and essentially I like to, my job really is mostly to liaise between our hospital and our school district. So any sprain, strain, anything that I can handle on campus, I do evaluate and then come up with a treatment plan and then carry that out at school for the kids every day. Basically that just, cuts down on people taking off of work and doctor's visits. Really my goal and our goal as a system is to kind of keep our kids out of the emergency room and really direct care to where they need to be. So I do evaluate and treat injuries or anything that needs my eyes, I evaluate and then try to make sure, work with our in-clinic staff to see if they need to see a sports medicine doctor. I refer to cardio, dietitian, done a few mental health services through children. I mean, I really have access to our whole system. So whatever our children need is what I am here to provide. But I do directly affect mostly just athletes. But I've, like I said, work with all of our staff. Right now, it's just me here, and we have about 250 athletes-ish in the district. So that's like pretty big ratio. In the next few school years, we're hoping to have more staff on campus, expand our athletic medicine facilities. So right now I work out of one training room, and so when I see 15 kids a day, or 15 kids in a period, that's kind of a lot for one space. I treat about 25 to 40 in a day, so it just kind of depends on the day and what sports are happening. With us slowing down with football, my hours are changing to where instead of being here from 10 o'clock in the morning until 7:30 most days, I'm slowing down a little bit, and I'm back at 10 o'clock to 6 if we don't have meetings on campus or anything. So we are just working, the motion lab at Texas Children's is really starting to do more research so that we can kind of work better to service our athletes and service our kids. So what that means is, like, I've reached out to the elementary staff. I'm also we'll start working with some of our more running sports, our upper extremity sports, just to kind of get some norms. We have this motion lab that's new as of, I want to say, the last 3 years, and they study motion patterns, so like throwing patterns, running, things like that. So they really want to, because I'm here every day, work with our athletes to make sure we are having good gait, good form, things like that. So parents will start seeing flyers, and as parent meetings happen, we will show up to try to get some research done for our kids at no cost to our community, just to get some research and then try to make our strength and conditioning programs better for our students and athletes everywhere and people. So that's kind of what I do. You guys have any questions for me? I didn't come with like the business card or a flyer, but I feel like one flyer can't catch all the things that we do, but pretty much my phone number floats around to everybody. I'm at school every day, including Friday, because I actually want to get my work done uninterrupted, and can see kids once a year. So, you'll find me on the high school campus around 10 o'clock every day.
And Erica's contact information is on the district website under health services. So if you're looking for her information along with ours, our clinic staff, she's on it. So, okay, thanks. So next we're going to go back to reports, and Emily McMurray, I've asked her to come speak. She is as she mentioned earlier, our new Director of Student Services, but she also has another role as our School Safety and Security Committee Chairperson. And we've got some upcoming safety checks by Region 6 and TEA, Texas Education Agency, will be coming to do an upcoming audit. So I just wanted her to talk a little bit more about all the work that's involved in that.
Perfect. Okay, so first, so under my job description, I do have safety and security, which a lot of health services kinds of things come with that. So we, like Celeste just said, we do have audits from the region. So Region 6 comes to each of our campuses unannounced. We get some information at the beginning of November. We got an email that said, hey, one of your campuses will be visited this month. Okay, so we did not know when that was or who that was. So that happened yesterday. Okay, of course, in the week before, when it's kind of crazy, but so that happened yesterday. They showed up at the intermediate school. Okay, and they check our doors because it's, you know, the rules that all exterior doors are locked at all times. It's a district policy that any classroom, our interior doors stay locked as well. So our teachers keep behind locked doors if students are in the room. So TBA, I mean, region doesn't check that, but they do check our exterior doors. They check. We, my group of people, we are required to do door checks, door sweeps on each campus every week. So we go check doors. Our officers also check doors, but when they walk through the campuses, and sometimes those are used as our checks, but we also are on campuses. All 4 campuses with the door checks. So that's another thing that the region checks is, do you have your door logs? Can we look at them? So that happened. We've gotten 2 schools done. Junior high has been done, intermediate has been done. So we will have the high school and the elementary will still be waiting to be done this year. A new thing that TEA has put out is called a district vulnerability assessment. So we call it a DVA. It's something that will happen every 4 years. This is the first year of the DVA, and we were chosen to receive our audit assessment this year. So that will, and we know when that is. That is December 4th. So on December 4th, TEA will come out here and they will walk all of our campuses. And we have a rubric and a lot of things, district that we have to do, upload a lot of documents for them to see, but then also on campuses, things that they're looking at. Some of the things they are looking at do have to do with our health services. So we have to have breathing control stations that are current at and accessible at every campus. And we do have those. We have to have our AEDs that have monthly inspections and they're accessible. So all of our AEDs are, we have a company that comes in and checks them monthly for us. So that's AED 123. They come every month, like clockwork, which is great. Our bleeding control stations are in our AED cabinets. Our AED cabinets, Miss Roberts had them moved down because they were kind of high, so not super easy for everybody to get to. So we did have those moved down on all campuses except elementary. It's still a little high, but it is it's okay down there. Also in that AED cabinet, bleeding control station, but there's also Narcan. Narcan is required to be on every junior high and high school campus. But we do have it on all campuses, which is recommended. Kiddos that, little kids that get into something at home and bring it and share candy with friends, you know, things like that. And Narcan we're able to get for free. Anybody can actually. So we do have that stocked in all of our AED packets. We also have access, all of our teachers and substitutes have access to Raptor Alert, which is a way that they can get 911 immediately, in their classrooms. And that's something that's also part of our district vulnerability assessment, that we have that and it's accessible by everybody. Okay. I think that's the only things that have to do with health services with the safety piece. Did I miss anything, Ms. Roberts?
I don't think so.
Do y'all have any questions?
Ms. McMurray's done a great job. It's a huge task, and she's done a fantastic job keeping track of it and taking care of it. So we appreciate her doing that.
Yes, very much so. Okay. All right.
Well, I appreciate you guys hanging in there. I know, again, we've gone a little bit over our normal time. Are there any other questions or follow-up from anything on your minds or any presentations, reports that we're doing today?
Billy, that's my business card on the table, if anybody wants to grab one of
Okay, well, thank you guys so much. Our next meeting will be in February 2025, hard to believe. And so again, you'll see information from me come across your email, reminders for the next meeting. And Ms. Brock and I would like to wish you guys a happy Thanksgiving. Next week school is closed. And then, of course, we won't see you for Christmas, so you guys have a good holiday. But again, thank y'all so much for your commitment and coming. We know it's a very busy time of year, so thank you so much.